But on the research and the public health side of the equation, plainly not nearly as robust. And I'm curious why it would be in a case where, if you think of just supply and demand, there's plainly a lot of demand for allergy remediation and so on. The public would like to know more, to suffer less, and so on. If the split I'm describing is accurate, why do you think there is such a big split?
Because the public doesn't decide which grants get funded. The trouble is that the drug companies are so powerful and they advertise so much that people just get the idea that that's what it is. And actually, the guidelines are warped. I've been on a guideline panel for asthma where we were told that we should focus on large controlled trials published in the last 5 years. Well, that basically means drug studies. The number of large controlled trials of tick avoidance that are being done is zero. No one could afford to do them. Companies have a lot of money and they do big, well-controlled trials, some of which are really important, but many of which are me too, or trying a new drug which is a very tiny variant of the previous. It's much more important to try and understand what's happened. I've written a history of food allergy, and there are 3 forms of food allergy, which are peanut and the other allergens that cause immediate hypersensitivity, eosinophilic esophagitis, and the alpha-gal syndrome. And why I pull those apart is because they're mechanistically completely different, causally different, and the reasons why they've increased are different. Peanut is probably ridiculous washing of the skin with detergents. EOE, we've just published a hypothesis that the processing of milk is a major part of that. Instead of pasteurizing milk at 84 degrees centigrade, all the milk you drink is heated to 135 degrees centigrade. It's dead, which means the particles are all changed. So, and we say weaponized to immunize the esophagus. And the third one, the alpha-gal syndrome, we believe is primarily due to the loss of dogs in the suburban areas. What happened in the early 80s is leash laws, and now the dogs can't get together to drive the deer out. And so we all have a herd of deer on our lawn, and the deer are covered with ticks.
This connection that Platts Mills has drawn between leash laws and a boom in the tick population is not his only unusual theory.
I was very well known in the 70s for saying that television had had a major effect on asthma. We published a paper in which we showed that if people watched a screen, they took less deep breaths. If they're reading a book, they still breathe normally. If your child is watching television and you touch their shoulder, they actually jump slightly because they're in a trance. They're not unconscious, they're not asleep, but they're in a trance. And during that time, the hypothesis was that that prevents their breathing, and the deep breaths are a better bronchodilator than albuterol. What's happened since then, if you want something really silly, is that children are no longer watching television because they've got cell phones. And the cell phones don't put them into a trance. And asthma has actually become less of a problem. The asthma doctors will be horrified if they hear anyone suggesting that asthma is anything but a total problem. But actually, peanut allergy has become more of a problem than asthma.
But a totally different causal mechanism, yes?
Totally different, yes.
What are your views on celiac disease and gluten allergy?
Yeah, Gideon Lack, who did the LEAP study, has been looking at celiac and seeing whether natural exposure to wheat in early childhood would prevent celiac disease. And I think he's got some evidence, but it's not of a level comparable to the LEAP study. The LEAP study was a tremendous breakthrough.
This LEAP study, that stands for Learning Early About Peanut Allergy, was published in 2015 by the pediatric allergist Gideon Lack. It argued that feeding peanuts to babies will actually reduce their risk of a peanut allergy. Much of the evidence came from Israel, where babies routinely eat bamba, a puffy peanut butter flavored snack. Full disclosure, some adults also love baba. Given what we've been hearing about allergies these past few decades, especially peanut allergies, you can imagine that many parents would be terrified to let their baby get anywhere near a peanut snack. Once a conventional wisdom is established, it can be hard to dislodge, which gets us back to the allergy with which we began this episode.
A whole generation of doctors were trained thinking that penicillin allergy was very dangerous.
And very common.
And it isn't. When I got here in 82, I already was saying things that, no, you don't need to worry about it as much as this. You need to ask the question and take precautions and be sensible. If someone had no history in 15 years, the chances that they're penicillin allergic are very small.
So what are some solutions? Can you talk about clearing people of penicillin allergy, for instance? By the way, the reason we're doing this episode is this is something that happened with me. I was told as a child I was allergic to penicillin. I avoided it for approximately 50 years. My current doctor, she said, we should test. So I did.
And you were negative.
I was negative, but I had to go through this, 2-day, first the test and then the challenge test where you actually get a little bit of it. And it's plainly something that's not scalable right now. So I'm curious what you think are solutions.
I'm waking my head. People have been trying for a long time. I can't tell you how many of the residents who apply for our fellowship have been doing a study on delabeling penicillin. So this is not something that people are ignoring.
Can you explain why it's so difficult? Because as much as medical technology has changed, everything from time-release medicines to the mRNA vaccine, there's so much technology that has accelerated discovery in medicine. Why is it so hard in this case to come up with a, let's say, cheaper, faster, more scalable way to clear people?
Well, there's quite a lot of literature that says you can't quite rely on a blood test. And that's what we should have, is a simple blood test for IgE to penicillin that absolutely solves the problem.
Kimberly Blumenthal is an allergy researcher at Massachusetts General Hospital and Harvard Medical School. She is one of the people who has been working on a better blood test for penicillin allergy.
We were trying so hard. I was working with Thermo Fisher Scientific. They have developed a blood test panel, and they wanted to see if it worked in allergic individuals from America. We identified in the Boston area everyone that reacted to penicillin in front of our faces in the last few years. We sent them the blood of these individuals, and I think it picked up like 3. It was like 3 of 20. It didn't pick it up yet.
What makes it so hard?
The conclusion was, they were allergic in the last 5-10 years. Maybe they weren't allergic now. So I have to bring them back, retest them. And then these patients, they're like needles in haystacks, right? We combed the records of all Mass General Brigham to find these 22 penicillin allergics. We really need to say, okay, you reacted to penicillin in front of my face today. Grab your blood and then send it to be able to know that they were true positives.
But you're making progress, it sounds like.
Slowly.
By the time you're 600 years old, this problem will be solved.
One of my mentors said to me, if you do your job well, you have no job. And I'm like, I just don't think that's going to happen. There's always something else. We need better tests now, back to the basic science in the lab. And then on the population level, we're thinking about implementing penicillin allergy evaluation in primary care. We just created a measure of delabeled patients in our healthcare system. And even just now that I can measure it in this clinic and that clinic, and I can see what types of interventions move the needle towards a higher percentage of delabeled patients.
So what would your message be to anyone who believes that they are allergic to penicillin now?
Get tested.
If we were to jump ahead 20, 30, 50 years or something, I would imagine that given the benefits of gene sequencing and machine learning and artificial intelligence, it would be pretty simple at birth to either understand everything that a given person might be susceptible to allergy-wise or just correct it.
I think it's possible, and it's also possible that we could alter our drugs to be less allergenic.
How would you do that?
Oh, goodness. Well, you'd have to know what metabolite of the drug is forming bonds in our body to make the allergen. And so it requires a lot of combined intelligence from different people.
I realize, though, as I asked that question, that it's a little touchy for you because I'd be putting you out of business. You okay with that?
Yeah, I would stop happy. If we have some sort of way that like everybody knows if they can or cannot have penicillin or any drug, or they're going to be allergic or not, if we were able to correct the 30 million mislabels in just America, I'm happy. I'm retired.
And you just open a florist shop or something like that? Be okay?
I do like floral design.
Well, there you go. I would like to thank Kimberly Blumenthal for the good conversation today, as well as Thomas Platts-Mills, Teresa McPhail, and Elena Resnick. Thanks also to Dr. Resnick for clearing my stupid penicillin allergy label. And thanks to Becky Kurth, Dr. Deb Jones, Dr. Lainey Hurst, and all the other medical professionals who helped turn me from a bone-tired coughing machine back into me. I am grateful. Making this episode was a good reminder of how much I love physicians, their drive, their curiosity, their willingness to admit what they don't know yet, and then to work ridiculously hard to find out more. Coming up after the break, we